What I'd like to talk about is talk about the clinical manifestations of FSH muscular dystrophy. A lot of you know a lot about this from personal experience, but I think one of the things that have been striving to do is understand what are some of the things that Dr. Tapscott talked about, which is why patients within the same families are different, why women are different than men. And these are things that we suspected over the years that there were differences, and now we're kind of getting a handle on this a little bit more. And it's helpful both ways. It's helpful for understanding the genetics, but at the same time also it's helpful for counseling, and it's helpful for, again, prognostication also, but also for giving clinical guidelines to the physicians taking care of individuals with FSH muscular dystrophy. So I'll start talking a little bit about some of the clinical features, and we'll start from the beginning and just go through this very, very quickly. But FSH is one of the most common forms of adult muscular dystrophies, and along with myotonic muscular dystrophy, it's probably the second most common form of adult dystrophies. And the prevalence or the frequency in a population has ranged between 1 in 8,000 to 1 in 20,000, depending on the studies that were done. The 1 in 8,000 value here is from a recent study that was done in the Netherlands. There are two types of FSHD that are genetically distinct, but as far as we know, they're clinically inseparable. You can't tell somebody with FSHD1 from somebody with FSHD2. And basically, that's why if somebody looks like they have FSHD clinically and have a negative testing for FSHD type 1, the next step should be testing them for FSHD type 2. Again, I mean, I think we now know why they're so identical, because even though the gene for most patients with FSHD type 2 is on a different chromosome, the effect of that gene is on chromosome 4 and also in the misexpression of the DUX4 gene. So it's even though the genetics are different, the ultimate mechanism is the same. What we haven't seen in patients with FSHD type 2 is some of the more severe forms of that we see in FSHD type 1, the infantile onset or the early childhood onset FSHD2. Again, with the exception of some rare families that Dr. Tapscott talked about who have combinations of 1 and 2, and those patients are more severe. So, and clinically, and this should not, for most physicians who are familiar with FSH, FSH has a very distinct presentation and a distinct examination when we see patients, with an onset up in the arms and face and a slow progression down to involve the trunk and then the lower extremities, first distally and then proximally. One of the things that we're learning over the last couple of decades is the importance of some of the truncal weakness that we don't typically examine in clinic, but is really important for the stability of patients. And as a lot of you know, there's a lot of abdominal muscle weakness that even if somebody has normal arms and leg strength, it can affect a lot of your function. And these features are really distinct from other forms of muscular dystrophies, and there are certain things that are really typical for FSH that are not seen in other forms of muscular dystrophy that make us scratch our head and try to find an explanation for. And there are some theories of why that might happen, but we don't have solid evidence for that yet. So one of the things is that the pattern, again, is very distinct. It's most muscular dystrophies have fairly symmetric involvement between the legs and the arms, usually proximally, whereas in FSH, there is an initial involvement up, and then it moves down. And the severity of the facial weakness is very distinct for FSHD as well. There's asymmetry in the muscle involvement, asymmetry from side to side. And I have a very good example of that I'll show you in a minute. And the absence of contractures in the joints. A lot of, if you're familiar with other forms of muscular dystrophy, around joints where muscles are weak, there's a lot of contractures. That rarely happens in FSH until in very much later stages of the disease. So these are some of the typical features. Again, this is the very typical appearance of the shoulders that are usually curved forward and sloping. The clavicle, which is supposed to be sloping upward, is flat. The pectoral muscles are atrophied, and you get this what we call the axillary crease, which is very distinct. And the scapular winging, again, you see in this gentleman, there's a big difference between one side and the other. This side is much weaker, or its scapular winging is much more prominent on this side. And this woman in the lower half of the slide is attempting to close her eyes, and you can see that she cannot do it. Even in the face, there's asymmetry, which is kind of unusual as well. Because if you think about the muscle that allows you to whistle and bring your lips together, it's one circular muscle around the lips. But even in this situation, you see that one side is weaker than the other. And again, this is kind of an unusual case. These two young women are identical twins. And you can see that they're kind of mirror images of each other. And I've asked them to flex their arms. And one of them can do the right side, the other one can do the left side. And both of those arms are completely normal, whereas this biceps on this side is completely wasted and atrophied. One of the things that I often do in clinic is try to kind of see how much improvement you can get by fixing the scapula, because that gives me an idea about how much gain somebody with FSH can get by with scapular fixation. And this is the patient here trying to lift their arms up sideways, and this is about as high as they can make it. And when I stand back and just fix their scapula, they gain a significant amount of range of motion, which is something that's very practical if they can regain that function. And so this is one of the interventions that has proven to be effective if it's done in the right person at the right time. We are learning a lot about a lot of the complications that happen with FSH and which is important, which is not. A lot of things have been written in the past about involvement of breathing muscles, involvement of the heart, swallowing muscles. And we've started now over the last few years to put numbers to those so that we can, and also try to figure out who's more susceptible to these side effects so that we can, again, counsel patients. And also, based on that information, generate guidelines. And so we know now from looking at breathing function in large numbers of patients is that breathing is impaired in about 10% of patients, but only about 1 to 5% require any type of breathing support. And this is typically occurring in patients who are more severely affected. There was a lot of back and forth over the last 2 decades about whether the heart is involved. Not so much as a dilated, what we call a cardiomyopathy, a weakness of the muscles of the heart, but predisposition to get some types of cardiac arrhythmias. But it turns out, really, when you look at large numbers of patients, there's really no sense that they get any serious cardiac arrhythmias. Swallowing difficulties have been occasionally reported and certainly patients with a lot of facial weakness have difficulty, manipulating the food in their mouth, but they usually don't have weakness in the back of their mouth and in the muscles of swallowing. And so they're really not, most patients with FSH are not at risk of aspiration, which are very critical issues, and because these are things that can be life-threatening. And again, a lot had been written about hearing loss, and this has really kind of has been focused down to an understanding now that really the only individuals who have FSH that get into trouble as far as hearing are those with a very large or with very few numbers of repeat left. So those with 1 to 3 repeats are really the ones who get hearing loss that needs to be addressed. And typically these are the early onset individuals with FSH, and this is very important for kids because you don't want to miss hearing loss in very young children who are developing language, as this may kind of throw off their language development. And we found the same with retinal vascular disease. Again, even though in some of the early studies done by Dr. Fitzsimmons showed that if you do very careful studies of the retina, there are a lot of tortuous blood vessels in the retina that look abnormal, but the vast majority of these individuals don't get into trouble as far as visual loss. And the only, as far as we know, in reviewing all of the cases that we could get our hands on, only the individuals, again, with the most severe form of FSH are the ones who are susceptible for that. And these are the ones that have to be monitored rather than everybody else. And then factors that affect disease severity, and some of that Dr. Topscott has touched upon. And again, we've learned more about this. We don't understand all of the variables that account for differences within the same family. One explanation is again the families where there's an SMCHD1 mutation on top of contraction of the number of repeats, so they have basically a double mutation of FSHD1 and 2. And it may occur in one person in the family, but the other person has either type 2 or type 1, and that would account for the big differences. And there may be other genes that we don't know about, but there may be other factors that also are not genetic that may be contributing to this. So again, this information that has been accumulated over the last 5 to 10 years is based on an improved understanding of genetics, but again, vice versa. We've used the clinical information to kind of understand the genetics as well. But now I think we have a critical mass of data that we can collect and put together into guidelines to help counsel patients and provide the care providers with reasonable recommendations that they can follow. And especially, I think as people who see a lot of patients with FSH muscular dystrophy, neuromuscular specialists are very familiar with this condition, but the general neurologist or the general practitioner really need help and some guidelines about what to do and when to do the certain things in patients with this condition. And so again, just show you some of the things that we now know about FSH muscular dystrophy. For many years, we said most patients are diagnosed in their late teens, early 20s, but really the spectrum of that is very wide, and it's very different between males and females. And when you look at women with FSHD, these bars are patients who are the age of diagnosis, and you can see down here the diagnostic age, and so you can see a fairly normal distribution. So again, like most commonly we see in the teenage years, there are some individuals who get diagnosed, but it can go all the way down, all the way forward to into the 60s, 70s, and 80s before somebody gets diagnosed. Where it's much different in males, where the peak is early on between 16 and 25. Some males get diagnosed later, but there's a striking difference between males and females in that respect. And there's, again, going back over this, the genetic influence that we now know is very clear. And Dr. Tapscott went over this. Patients with FSH type 1 have between 1 and 10 repeats, whereas normal individuals have more than 10 repeats on both copies of chromosome 4. And there's a clear distinction between patients who have 1 to 3 repeats that typically have the more severe disease, and on the other end of the spectrum, the 8 to 10 repeats. And those are the patients who are likely to be not non-penetrant, meaning that they carry this mutation or this contraction, but they're not showing signs or may show signs later in life. But even within those groups, though, you will see a big spectrum. I mean, 1 to 3 repeats. Again, I mean, almost, I would say, none of the infantile onset or early childhood onset FSH muscular dystrophy have anything greater than this, typically. But there are adults who show up with FSH and get diagnosed in their late teens and 20s who have 1 to 3 repeats as well. So even within those groups, there's still a wide spectrum of severity. And so the severity in relation to the muscle involvement also is reflected, again, as we talked about, in the hearing loss and retinal vascular disease. And here we're emphasizing symptomatic hearing loss and symptomatic retinal vascular disease causing visual loss. And so this takes us to what has just been published last month, and these are the American Academy of Neurology guidelines, and these are evidence-based guidelines. And this took way too long to put together, but it took about 3 years of meetings and going through a large, not such a large body of literature, but just going very carefully over 176 articles that we first had to decide where there's evidence for some of the things that we care about knowing for patients with FSH. And so we had a whole list of things, but for a lot of them, there was not even enough literature that is reliable to look at and make recommendations. So we had to scale that back down and really concentrate on where we had evidence. And it was done in a very systematic way. And these are the topics that have been covered by the AAN guidelines. And this includes, the genetic testing for FSHD type 1. And one of the things that had never been kind of established is how accurate is the testing, how sensitive and specific it is. And this has been established, and the test at most institutions is very good and very reliable. And then we looked at factors that affect loss of clinically meaningful milestones. And again, there is now established evidence that the number of repeats, sorry about that, play a big role in the severity. We've looked again at all of the clinical trials that were done in FSH, and again kind of confirmed that really none of them should be prescribed for patients because none of them showed any efficacy. We looked at hearing loss and determined that that really the only patients with FSH that need to be screened for that are the infantile early onset or patients who have 1 to 3 repeats. That the heart, there's no evidence that screening is required for the heart. Breathing, again, we've outlined, we now know more or less how frequent this is. but we also know that it is a certain patient population within in the population of patients with FSH that are more susceptible to that. Or usually these are the patients who are more severely affected, have a lot of truncal weakness, and patients who are wheelchair bound. We talked about management of pain. There are a couple of studies that looked at the frequency of pain. A lot of patients, as you know from personal experience, those of you who have FSH, musculoskeletal pain is a big issue in about 80% of patients, but really only severe, as reported by patients, about 10%. They looked at exercise. Again, that's something important, and a lot of patients ask us about exercise. And it's been determined that exercise is not detrimental, especially aerobic exercise, and should be encouraged, but really should be done, with the help of an experienced physical therapist. Scapular fixation, again, can be offered cautiously, and it can be done in selected patients. It doesn't make any sense to do it on somebody who has a lot of arm weakness, who would not benefit from increased range of motion. But if somebody has good biceps and triceps and deltoid muscles in that arm, and if you do the manipulation at the bedside and they gain a lot of range of motion, then these are patients who may benefit from this surgery. Again, one of the things that has happened is that the evidence is not very strong for a lot of things, but we had the luxury of kind of putting the clinical context and using common sense to create guidelines that are useful for patients. There's a lot of issues that are not covered by these guidelines that need to be addressed. And one of the things that we've been talking about with the help of FSH Global yesterday, we were talking about consensus guidelines to address issues that are important for patients that are not covered by these guidelines, because there's no published evidence for that. But so this is a link to the guidelines. I don't know if